Alright guys, let's get busy talking about our penile pathologies. In our penile pathologies video, we're going to be talking about three main buckets of pathology. We're going to be talking about Peyronie disease, which is all about chronic microtraumas. And then we're going to move on to talk about ischemic priapism, which is going to be an acute pathology all related to blood flow. And finally, we're going to talk about squamous cell carcinoma, which is going to be about neoplastic changes that happen over a period of time. So let's get started by talking about our Peyronie disease. And essentially, the pathophysiology here is chronic microtraumas to the penis. This is usually going to be in the setting of intercourse that's really rough or excessive aggressive masturbation. And essentially fibrous scar tissue deposits in the tunica albuginea. And this is because the chronic microtraumas lead to deposition of scar tissue over time as the penis tries to repair from those microtraumas. And this can lead to distortion of the penile architecture. So let's take a closer look at what this exactly means. So if we were to take a look at our insult here, let's say the tunica albuginea is this blue fascial layer here along the penis. It's one of the many fascial layers we have in the penis, and we can acquire trauma to this. So my trauma is going to be this little pink X here. And if we were to demonstrate this in longitudinal view, this pink X would be here. And we can also show this on the anatomical portion of our penis. The pink X would be here. And here we're going to get fibrotic scar formation. It's going to cause a shortening effect. So it's actually going to pull that tunica albuginea to be shorter, and it's going to lead to this architecture of the penis actually curving in a certain direction along this formation of the scar. And that's how we get this curved shape of the penis that we can appreciate over here in the gross specimen. And this is due to the chronic microtraumas with intercourse and masturbation. And so classically, this is going to present as a sexually active male who comes into clinic complaining of a curved or a painful penis every time he gets an erection. This can lead to performance anxiety or inability to get erections, or if they do get erections, it's going to be painful. And so, like I said, the etiology here is going to be repeated trauma during intercourse, the presentation, a curved penis plus or minus pain, as well as possible erectile dysfunction. This can lead to sexual and performance anxiety. Now, in terms of our treatment here, we can use collagenase injections to actually get rid of the scar formation that has occurred here. So it's like an enzymatic reaction. You inject the collagenase and hopefully it's going to break up that scar tissue. You can also decide to do this surgically. So you can go in and surgically remove that scar tissue in the hope to remove that bend in the penis caused by that scar tissue deposition. So in terms of management, collagenase injections, surgical repair. And it's important to denote that this disease process is different from a more acute traumatic disease of the penis, which is going to be penile fracture. And so in penile fracture, it's going to be a severe bending acutely during intercourse. So whereas in Peyronie disease, it was like microtraumas from intercourse, in penile fracture, we're going to get a severe bending during intercourse, and this is going to cause a rupture of the corpora cavernosum. So the rupture would happen here in the corpora cavernosum. We would expect a really large focal hematoma where that fracture happened, and this is going to be an acute penile pathology as opposed to Peyronie disease, which is going to be a chronic penile pathology, and that's how you're going to differentiate those two on test day. So now that we talked all about Peyronie disease, let's go ahead and move on to ischemic priapism. And ischemic priapism is going to be an acute pathology of blood flow, and it's going to be a continuous erection lasting longer than 4 hours. And this is due to some type of obstruction of blood flow leading to an erection that lasts a really long time. Normally, erections are only supposed to last upwards of 30 minutes, and this is for the purpose of intercourse. The penis should not be engorged with blood for longer than that. So if we see a penis engorged with blood for longer than 4 hours, this is concerning because it leads to mechanical obstruction of blood flow. And we know that anytime we have obstruction of blood flow, we are at risk for ischemia and necrosis. And this is causing penile ischemia because blood flow cannot leave the penis, and it's just continuously bloated with blood, and this actually creates like a tourniquet effect. So this green that I'm drawing around here is like a tourniquet around the base of the penis. It is preventing venous blood from leaving the penis and preventing new arterial blood from flowing in. So the venous blood is kind of being shunted back upwards, and then the arterial blood is not able to get in because it is completely clogged with venous blood from this tourniquet effect that is happening from this continuous erection. Now, in terms of a classic vignette, there are going to be two ways that this may present on step one that I think are really high yield. The first one is going to be a patient with sickle cell disease. So essentially what happens here is patients with sickle cell disease, their sickled red blood cells can clog up the drainage system of the penis, and this leads to obstruction of venous outflow, and so they get a really clogged venous system. This erection persists and persists, and they cannot drain the penis because they're in sickle cell crisis. And so this is an important vignette to be able to recognize on test day. The second category of vignettes is going to be patients who are on some type of drug that can lead to priapism. One of the classic ones is going to be trazodone. So trazodone, the vignette is classically going to be an older gentleman, usually in a nursing home, so 75-year-old male in a nursing home, maybe suffers from dementia and uses trazodone to help with sleep. Trazodone can actually lead to continuous erections, and so this patient may have woken up with penile pain, may have had an erection for 5 or 6 hours, and this is due to the trazodone. The next class of medication that I think is even more high yield, and you actually have to understand the mechanism, is going to be sildenafil. So let's talk about that mechanism, and let's go back to some basic physiology here. In terms of the mechanism of how erections happen, the key player here is cyclic GMP, and cyclic GMP is actually going to promote smooth muscle relaxation, and smooth muscle relaxation is going to promote arterial blood flow, which leads to erections. Now, in order to continue this or to help patients get erections, we can use a drug called sildenafil, and sildenafil is going to inhibit an enzyme called PDE5, and PDE5's job is to convert cyclic GMP, which is the active form, into the inactive GMP. So if we inhibit the enzyme that's causing this conversion, which is what sildenafil does, sildenafil will knock this guy out, and it's going to promote more active cyclic GMP. This is going to lead to more smooth muscle relaxation and more arterial blood flow, thus helping patients get erections. However, this can go awry if there's too much towards the pathway of erection promotion, and this can lead to priapism, and it can lead to an ischemic penis. So the two drugs to know on test day are going to be sildenafil and trazodone as the real high yield ones that can lead to medication-induced priapism. Now, when it comes to treating our priapism, it's going to be immediate treatment because this is a reproductive emergency, and the way that this is done is with corporal aspiration. So a large needle is inserted into the corpus cavernosum, and blood is actually drawn off from the corpus cavernosum in order to relieve that swelling of the penis and hopefully allow more new arterial blood in to refresh that clogged venous blood that was there before. Additionally, we can give patients intracavernosal injections of phenylephrine, and phenylephrine is a pretty potent vasoconstrictor, and so it's going to constrict the blood vessels that were like trying to pump arterial blood flow into the penis, and this is going to relieve that tourniquet effect and allow the erection to go down. And then if none of these things work, we can actually move on to surgical decompression. So I just want to highlight here corporal aspiration, intracavernosal phenylephrine, and then surgical decompression if those don't work. And this is always going to be in the setting of an erection that's lasting longer than 4 hours, usually accompanied by pain. Lastly, let's move on to talking about our squamous cell carcinoma, which is going to be neoplastic change of the penis itself. This can happen on the shaft, it can happen on the glands, and this is going to be a chronic pathology. And essentially here we have 3 different precursor lesions, and these are in situ lesions, meaning that they are confined within the basement membrane, and these will eventually transform into a squamous cell carcinoma. And so it's important that you be able to recognize what a squamous cell carcinoma looks like on exam day, and there are some really high yield features of squamous cell carcinoma to know. So let's go ahead and zoom in and take a look at this. So what we have here is a keratin pearl, here's another one here, and these are classically going to be described as onion skinning deposits, and so you can appreciate this onion skinning here. It almost looks as if you cut an onion in half, and you can see like the rings of the onion. This is a classic picture of a keratin pearl. This is what you expect to see in a squamous cell carcinoma. Now let's cover the 3 lesions that you need to know for test day that are going to lead to squamous cell carcinoma. So I first want to start out by drawing a picture of a rudimentary penis. So here is my shaft here, and then here is the glands up here. I'm not the best artist, but you can appreciate the different anatomy here. And I'm actually going to put 3 different marks here. So I'm going to have A, I'm going to have B, I'm going to have C. And this is because on test day you may be asked about where the specific precursor lesions show up and what they look like. So let's go over each of them. We're going to start out by talking about Bowen disease, which is going to be a leukoplakia, aka a white plaque of the penile shaft of the penis. So we expect to see this on the penile shaft, and it's going to be a white plaque. So I'm going to go ahead and highlight B as this gray lesion here. And so in a question, they may have a penis labeled with like 3 different labels, A, B, C, and be asking you to choose which one. And if it's going to be Bowen disease, you're looking for a white plaque on the shaft. Now let's talk about the next one, which is going to be erythroplasia of Kara, which is going to be an erythroplakia, aka a red plaque, and this is going to be on the penile glands. So I'm going to put A here as this red plaque, and this is erythroplasia of Kara, and we expect to find this on the glands or the head of the penis. And then lastly, we have our last lesion, which is going to be boinoid papulosis, which is going to be reddish papules throughout the entire penis. So I'm going to kind of draw papules out here all along the outside. This would be representing choice C. This may be how a test question is written. They're asking you about the different locations and the different appearances of these various penile lesions that will eventually lead to our squamous cell carcinoma, characterized by our keratin pearls. And in terms of some risk factors for developing squamous cell carcinoma or these precursor lesions, it's important to know that this can be caused by HPV and it's going to be more common in uncircumcised males. So I hope you guys enjoyed this content on penile pathology. Can't wait to see you guys in the next video. Bye!